G'day. Welcome back to episode 53 of the Sports Medicine Project. I'm here in the back of a juicy van with Kelly. How you doing?
I'm good.
That's good. We're currently on holiday at the moment, so apologise.
Milford Sound.
Yeah, apologise if the audio quality is not great. Should be pretty good. I mean, we're in a forest in the back of this van. A little bit of rain on the back, but it does feel a little bit like a podcast studio. Yeah, we're currently in New Zealand, so I've got 2 weeks here. We just finished the Queenstown Marathon, and we're in Milford Sound at the moment, about to embark on a lovely couple of hikes and a couple of boat cruises. But yeah, we're going to talk about the marathon today, a couple of different ideas, I guess what we got from there, what we learnt from it, definite highs and lows, lots of lows if you've seen our Strava, but a couple of things that made us think, well, more, I don't know about you, but I was thinking, and I think this now because of the podcast, every time I do something, how it relates to the clinical life and the lesson I can learn from it. So I got a couple of good ones, but yeah, you want to get cracking because we got part 1 with Andy Bryant.
In this episode,
Yeah, which is, I can't wait for, and if you follow Andy on Instagram, he's got 50-something thousand followers, really intelligent guy. It was a great episode. I was so shocked. I was quite disappointed because I was expecting us to disagree on a couple of things, and obviously there's a couple of things that we disagree on, but a lot, probably 98% of the things we did agree on.
Yeah, I got a lot out of it too. I thought it was an enlightening conversation and just a different perspective from the podiatrists that I have spoken to in some ways. Or just maybe not a different perspective, but different treatment philosophies, maybe is the word I want to use. Or I guess different ways to skin a cat, but still get the same outcome.
Yeah,
What?
I've never heard you use that analogy in your life. Skin a cat.
There's many ways to skin a cat.
Yeah, I've just never heard.
So brutal though. I don't really like it now that I've thought about it a little bit more.
Never heard you ever say that before, I don't think. But yeah, you're exactly right. I don't think his treatment philosophies are that different to my own, really. Like less is more, minimum effective dose, tissue capacity is usually...
I would say you go to orthotics far more than Andy would, though.
Yeah, that's true. That's very true. And that was probably something...
My thoughts throughout it was that you would often, following the tissue stress theory, prescribe an orthotic, whereas Andy would, from what I can gather, and I'm making assumptions based off what I pulled from our conversation, he would go more a capacity building route before the orthotic. Yeah. Whereas you would do the orthotic while capacity building. Yeah. Yeah?
And that's probably where we differ. And a couple of things that he did mention, he has really long follow-ups as well, like 4 weeks or even a couple of months. And that's probably something that we do disagree on. I think that you can get, and this is just my opinion, whether it's evidence-based or not, it does follow a logical order. I think that I would be more likely to get someone better quicker with using an offloading tool while also building their capacity at the same time. Similar, and it's an easy one to think of, if you were to give someone for an Achilles tendinopathy a couple of heel lifts, and also the strength and conditioning. One, it should make them feel a little bit better while they're dealing with it and hopefully unload it to the point where the capacity building can be the driver and possibly get them better quicker and back to their normal activity quicker. But hey, could be wrong. And that's why we do this podcast, to learn these kind of things. So
yeah, I did ask Andy about, does time frames extended with that sort of method, but you'll have to tune in to hear what he says. Yeah, you'll have to listen.
It was good to hear, and lots of things, he even agrees, the arch doming and lifting up the toes is not useless, but it's such a low level of load that it's probably not enough of a stimulus to create any adaptation. That's something I definitely believe in. And talking about the footwear and things as well, that was awesome. I
think a lot of what Andy was talking about though, which I actually didn't realize until towards the end, it was probably more so for general population rather than runners or active people. Is that right?
Yeah.
That's what a lot of, I just, my brain was sort of elsewhere. I thought we were talking a little bit more about active people and runners and things like that, but it was probably more so targeted towards just general pop.
Yeah, I'm sure he sees a mix of both, but yeah, you're right. He did say, and we probably should have introduced Andy and he's known as the barefoot podiatrist, and he's a big advocate for, flexible, low pitch shoes, very wide anatomical fitting shoes, and natural is best, tissue capacity, and all that kind of thing. I'm trying to think of a better way to explain it, but I'm sure he'll be okay with that.
That's definitely something that I probably need to pay more attention to, is people's foot width, I think.
Yeah, and I completely agree. There's people that, and I always say this one line to patients, so please feel free to steal it if you think it's any good. I will say to patients that have a little bit more of a unique foot that shoe companies generally make shoes for what they think is the normal foot, in quotation marks, and if you're anywhere outside of that, it's very likely the foot may not fit as well. And typically if you've got a little bit more mobility in your foot, whatever you put it into, it's able to kind of conform to the environment. So if you put it into a narrow shoe and you have a flexible foot, it will just conform to that because you've got that extra mobility. So knowing that, it's probably better in your case to look at a more anatomical fitting shoe. But I definitely don't agree that it needs to be for everyone.
Yeah.
Yeah. Awesome.
Cool.
Anything else you got from it? No?
Yeah, probably, but I don't have it on the top of my head right now.
Right. Yeah, right. Well, you want to get to your highs and lows. You start with your highs and your lows.
Yeah, so Queenstown Marathon Recap. So that was 2 days ago. Still very sore. But big high was that's been a bucket list marathon for me for ages. Since pretty much I started started running really. I've always thought it looked like such a beautiful run and one that I've wanted to do. And so got to do it and finished it, which was really exciting. And my ultimate goal was just to be able to get to the start line without any injuries, and then even more so to get to the finish line without any injuries. And so far I think that I have achieved that, which is good. Haven't really tried any running yet apart from our little shuffle yesterday that we tried to do, which was challenging. But yeah, that was a really big high for me. Another high is that I certainly learnt a lot about how I would maybe prepare differently for a marathon. I think, as we have spoken about on the podcast, so I have had a couple of niggles over the past couple of months, so I did have to modify my training to sort of cater for that. So I wasn't necessarily able to do the build that I was hoping to do.
Would you get a coach next time?
Yeah, I think I'd really want to do that. I do prefer half marathons. I'm going to just go out there and say it, and maybe that's because that wasn't as enjoyable of a marathon as I maybe had envisioned it would have been. But I do think I want to maybe look into getting a coach for next year and try and have a really good strong running season next year.
Yep.
Yeah, the weather was predicted to be raining and horrible, and it turned out to be a really great day. So that was also a big high for me, because it allowed me to sort of take in the marathon. It was a beautiful course, and I think, had I known what the course would have been like a little bit more and been able to prepare for it better, I think I would have enjoyed it a whole lot more. But we'll get to that when we talk about our lows. What were your highs?
An interesting one I took and about the marathon, but the pain after and just my quads and hips being quite sore, it made me think of when we give rehab and things to patients when, they may not have done, and we'll use running for an example, if they haven't run for a couple of months or 4 or 5 months, or they haven't done any kind of exercise therapy like what we're giving them in the rehab, and they do the rehab or they do the meaningful activity and they pull up sore the next day or they pull up sore for a couple of days, it just made me think that whether that pain that they feel the days after, and always pre-framing and saying it's very likely you'll be sore after, it made me think whether the pain they actually feel is from the pathology that they've seen us for. And we use an Achilles as an example. Their Achilles is sore. Is it the fact of, it's the pathology that's giving you the pain, or that you're doing something new that you haven't done for 4 or 5 months, or you're doing something in the rehab that we've given you that you've never done in your life, like some hopping or some jumping, or very likely a combination of both.
Don't you ask them that though? I always ask them, is that is that your symptoms? Is that the pain, or is it a different type of pain?
Well, I don't know.
Because you can tell the difference.
Yeah, I don't know if they might not be qualified as of yet to be able to. I guess they might be able to tell the difference, but then how do we know if they're feeling it in the same area? And I use the example when I'm with patients and say, if I didn't lift my hand above my shoulder for 2 weeks and then I decided to do it, it's probably going to feel a bit sore and creaky and stiff, but it's very likely I don't have any pathology there. It's just something new that I haven't done in a while. So whether it just made me think how much of the pain is from the pathology and how much is them from doing something new. And obviously there's some pathological pain that is the driver there, but also just saying that to them, because it's very likely they'll be sore and stiff after doing something they haven't done in a while. And I think pre-framing it to say, you probably are going to be sore, that's completely normal, because we're not going to be there obviously the days after to reassure them that it's normal. And for them, if they do something they haven't done in a while and then it's painful and we haven't said anything, then they'll be like, I've gone backwards, I can't do it, I need to stop everything, I'm in pain, that kind of thing.
Yeah. I guess if we talk about an Achilles tendon for an example though, your Achilles tendon isn't often not going to be like sore like a muscle soreness, DOMS, after doing calf raises. Your calf muscle is, if it's that kind of soreness.
It won't be?
Your tendon's not going to get DOMS.
But could it be sore from just not, if you haven't used it that way in 3 to 4 months? Like if you haven't run for 3 to 4 months and then you go and run, is it possible your Achilles might be sore?
I guess so, but I don't know if that's a DOMS. I think DOMS is muscle.
Oh, I'm not saying it's DOMS, just generalised soreness, or just generalised, what's the word for sensation? A generalised...
sensitivity?
Yeah, just a generalised sensitivity.
Mm.
Like if I don't run for the next 5 months and then I go out and run, I would, and again I'm not going to say it's 100%, but I would think it's possible that the Achilles tendon may be sore or the calf may be sore, and you're right, it's probably more likely to be the calf. But I think it's a lot easier to maybe pre-frame that for them just in case it is. Possibly. I don't think it could be DOMS, but it could be a sensitivity. You don't think it's possible?
No, I do. I think I do it though. So you just need to catch up.
Oh, right. Well, I'm a new graduate here.
Yeah. No, I do more rehab though, so I think that's something I'm conscious of, is when I'm taking someone through hard things, I'm often saying to them, you might be a bit sore after this, but yeah, you'll understand.
Yeah, I just tape people and stuff. I do the rehab. You are right. You you give a lot more rehab and have given more rehab. But that marathon made me think of that, and pre-framing. I guess it's like, what's the not under promise, over deliver. Just saying, yeah, you might be sore. That way you kind of cover yourself when it is, and then that way if it's not, they come back and you're like a genius, which is cool. But yeah,
it's not a bad thing to be sore.
No, but they are very likely to think that it is. They're likely to think that pain is bad.
Okay.
You don't think? All your patients love being in pain?
Well, people that are pretty active it's not the first time that they've got soreness after doing something hard.
Yeah, but you would have to admit that it's very likely that if they're in pain, most people that practitioners are going to be seeing are going to think that's a negative. You don't think?
No, I disagree.
Really?
Yeah. Do you not have patients that finish a workout or they come in, they're like, oh, it's a bit sore, but it was good. I felt like I did something.
Yeah, but not all of them, and nowhere near the majority. I would think that the majority, most of the patients that I see, and you must see a different population, you might see all Olympic athletes, but the people that I see typically come to see me because the pain is not good. They don't come in and say, it's...
Maybe it's because I've pre-framed it better than you have.
I don't know. I think you were wrong. I do. But anyway, we'll put up a poll on the Instagram and we'll say something as simple as, do your patients like to be in pain?
Maybe I calculate the appropriate dose.
Yeah.
And you give them too much.
Maybe. All right. We'll leave it as all your patients love being in pain, and I usually try to get people out of pain. We'll leave it as that. No, I get what you're saying, but anyway, we'll move on.
Yeah.
Was I saying my highs? Yeah, the shoes are great. Alpha Fly 2s were really, really good. Blister prevention. I got a blister after I just said the shoes were great, on my right foot, and I was talking to Nathan Pope about this, how the Alpha Flies fit really well, and then I got a blister on just at the base of my first metatarsal, and I put a little hydrocolloid pad on it. I put a little ergo pad in my shoe, and I was fine. So that was really, really good. So that gave me a bit of confidence, because I tend to see a lot of people with blisters, a lot of trail runners with blisters in the clinic. So I was excited for that it worked. And I'm very excited to continue running. I've downloaded a couple of books to read on the trip. Endure, The Science of Running, and I'm going to try and do my own programming, and then probably get a coach for the Gold Coast Marathon, I think. And then also talking with other runners about testing. So I was talking to a couple of people about like lactate testing and all the testing that they do at the university, and it was so cool and so insightful. It was just so interesting to hear about that kind of stuff, where they work out your zones and your LT1 and LT2 and all that kind of stuff, like, and then your paces based off that, like, and they do it a couple of times a year. But that was awesome. Yeah. What about your lows?
Oh, the lows.
If any.
If any, yeah, no. It was hard. You know those days where you go for a run? Like, let's just say you go for a 6-kilometre run, and there's some days that you're like, I just feel great. And then there's other days where you're just like dragging your feet. Mm-hmm. I was not having a good running day. At no point throughout the entire run did it feel comfortable or good or easy or anything. And I just remember running along this part, and it felt like I'd been running for hours, and I looked down at my watch, and it's been 17 kilometres, and I still had so far to go. And I was like, oh shit, this is gonna suck. So it was hard. And that's not the course's fault. That's entirely my fault.
You're pulling the excuses out.
No. I significantly underestimated the difficulty of Queenstown Marathon. When I, saw that it was undulating hills, I did expect sort of rolling slight inclines and slight declines, but it was steep up, steep down. The steep ups took it out of me, and then the steep downs, they were on gravel roads where I didn't feel like you could run fast, or I hadn't prepared myself enough to be able to run fast down them. I felt like I was either going to like roll my ankle on a rock or slip or something like that. So it was a bit of a shuffle down the hills. And yeah, it hurt. Pretty much hit the wall at 17 kilometres and then just like shuffled my way to the end. Was nowhere near the time that I was hoping for. However, I very quickly sort of rearranged my goals throughout the marathon, and sort of was like, all right, maybe under 4 hours, we'll see how we go, otherwise just finish. And I did just slip in under 4 hours, so I was happy to get there. And yeah, certainly learnt a lot about how I would prepare better next time. Definitely would have gotten out onto like Glenrock trails and ran on that as much as I could have in retrospect. Like, I sort of thought Glenrock might have been a bit like hardcore for a marathon of undulating hills, but not at all. I reckon that would have been the perfect training to do a few laps around Glenrock for that particular marathon. Yeah. What are your lows?
My lows, similar to yours. I think it was windy, my shoes, if those things were right, I probably would have just got under, because I only just missed my time by 39 minutes. No, I'm not making any excuse at all, other than my training and my ability to actually do the 3 hours. I wasn't even close. I will, and I don't want to be the guy that says these excuses, but I am going to say, and even if it was a flat, I'm going to say firstly and pre-frame it, if it was a flat, slight decline, 42k with a tailwind, I still wouldn't have got the 3 hours. I was the opposite. I felt really, really good. I was like, all week the taper felt really good. All my nutrition was good. I feel like I'd eaten enough, but not too much to feel full, and I didn't feel lethargic or anything like that. But the first 5k were great. I was on target 4:15. and we kind of come,
5K.
yeah, we come off you run along the road, and then you come on into these trails, and we'd driven past the trails when we went bungee jumping, and I was like, oh, sweet, that just looks like you're running along the river, nice and flat, and then when you got onto it, it was these little, like 5 meters of incline, 5 meters down, up, and then down,
and they were
up.
steep.
Yeah, they were proper steep.
They were steep hills.
Like, I would go from 4:15 to like 5:20, and then down to 4:15 to 5:20, and then I would go down, because I would sprint down because the shoes were able to really help me do that. I would get to like a 3:50 pace going down, and then I would have to come back up and then flat. And my problem was that I tried to sprint the downhills, and my quads just couldn't handle it. By kind of 12-13k, they were feeling quite fatigued, so that really did me in. And like Kelly was saying, at the 15k, there was this steep, like 40-meter hill, and I thought to myself, there is no way that I'm going to get even close to 3 hours. So I readjusted to 4:30 pace. I thought, once I get onto the second half, should be sweet. Then I adjusted to 4:45, and then once I got to like 4:57 pace, I was like, you know what? I'm going to adjust to just finishing. And then I was really struggling.
Isn't it funny? Because the whole time leading into the marathon, you were like, you just need to have one goal. Because as soon as you give yourself a moment of weakness, and then there you
that
go,
weakness
giving
come
yourself,
up very
giving
quickly.
yourself your
That Moose guy was right. He always says respect the marathon, and I knew, and I was like, I just probably have to go through it and have a shitty one to get it wrong and to experience it. But I did not think it would be like, I didn't think it would be that bad.
Yeah.
I was doing the.
You know, as I was saying, sorry, I interrupted you.
No, you go.
Yeah,
I don't. No, you actually go.
I did a 32-kilometer run a few weeks ago and felt great. The whole run just felt so comfortable. No issues. I just can't believe how different that was. But I think it was the hills. I think it was the hills that really cooked me.
Yeah, it had to be. It had to be. I would never, around the 17, 18 kilometer mark, I started to feel my legs, not even cramp, but I could feel them on the verge, and they did eventually cramp around the 30k mark. But I can't imagine that could have been from anything else other than the hills and just like that eccentric control running down the hill. But yeah, if you listen to this and I had discussed the 3 hour with you, I knew, and I know that you would have been in your mind going, this fucking idiot thinking he can run 3 hours. I just want to say that you should have just knocked some sense into me, and there's a couple of people I can think of
that tried to.
Yeah, I do remember.
Yeah, no, I was just thinking that too. I was thinking all of like the proper runners that listen to this podcast are probably like these these little.
The only person that was kind of
humans.
close, like Joe Ryan, I remember messaging him like ages ago, and he's like, he didn't say no, but I remember him. The message, he was like, oh, I know a lot of really good runners that haven't can run like a 1:23 half and haven't been able to get under the sub 3. And then I was like, yeah, you're probably right. And then like a week later, I was like, no, I'm actually going to go for it. So I should have just listened and set a more realistic goal. But it's good, and I'm happy that we're not hating running. You know, there could have been a bad experience where you don't enjoy it. I'm really keen to get stuck into running. Now, properly.
I'm keen to have a few, like a month or 6 weeks of just unstructured trails and stuff while we're on the rest of this holiday. And then, maybe like halfway through January, start to get back into it for next year, I think.
Yeah.
That's my plan.
Other one, Morton, had Pure Performance. Pure Nutrition gels. And then at the 32k mark, I had a Morton and then instantly felt sick. So I'm off Morton for now.
Actually,
at the
that
moment.
was something that I was happy about. I didn't get any.
Yeah, you did well.
All my nutrition digested very well. I was happy about that.
And don't take that as the nutrition did anything to my time. It wouldn't have mattered if I had the most perfect gel anyway. Nothing would have changed. And the last low I'll leave you guys with is, and we're going to put this on our Instagram, is there was a recent study that came out with Stuart Warden talking about sport specialisation and bone stress injuries. And basically, and it seems to be happening more in female athletes, and they do these studies in collegiate, is it NCAA or XC runners over in the States, where if they specialise early in running, they are much more likely to have bone stress injuries when they're older. So any parents listening to this, I don't know if there is, there might be. I think that early sport specialisation, it's pretty clear now. I know I've had a fair number of studies, but I would say it's pretty clear now that early sport specialisation is a significant risk factor for further injury.
I was thinking about this the other day. I wonder, like, to what level that is, because often, during high school and things like that, in PE and sport, you have to play like a bit of touch footy or soccer.
But it's not often. It's not consistent.
So yeah, that's what I was wondering. Like, is that enough of a variety if someone's predominantly doing running to get that multi-directional stress, or do you think they have to actually involve themselves in a team sport?
I think it's got to be, and the average would be, maybe 1 or 2 training sessions a week and then playing on the weekend. Because you think when you're in PE, when you're in high school and primary school, how involved are you really? I mean, I went to an all-boys school and we were heavily involved, but I don't know if that was the norm.
I would often forget my shorts.
Yeah, or you just kind of kick the footy, and you might do it for 20, 25 minutes, or the people that really love sport play the majority and take over and hold the ball and stuff.
I remember not wanting to get sweaty.
Yeah, exactly, things like that.
so I just tried not to.
And you might do that, maybe once or twice a week. So you might do 20, 30 minutes, and then you might change in 2 weeks and do swimming or volleyball.
Oh,
I think
that was fun when we did the pool.
Yeah,
I remember I loved cross country. That was the only time I ever wanted to play or gymnastics. That was fun.
Yeah, that would have been good. But yeah, interesting. So I mean, it keeps coming up, but I wonder, if they're going to be able to get the dosage right and figure out how much, which is going to be really hard to do that prospectively and follow people over time to see if they've trained. They might do 2 hours a week of a multi-directional sport. Does that reduce your risk for injury?
Do you remember if it said that at all in that study?
No. I haven't actually read the study. I just saw it was... I'm happy to say that I didn't read the study. I saw it was Stuart Warden.
Abstract boy over here.
He was an absolute weapon in the bone injury. And then I quickly read the conclusion because we don't have any service. But I will read the study properly. Awesome. Well, enjoy this episode with Andy Bryant, guys. It's an absolute ripper. Part 1 this week, part 2 next week. As always, have a lovely week and we'll talk soon. Alrighty, everybody, welcome back to another episode of your favourite podcast, the Sports Medicine Project. Now, I say this every episode with every single guest, but I'm an extra bit excited today because we have Andy Bryant on the podcast. Mate, how you going? Thank you so much for coming on.
I'm well, thanks for having me.
Beautiful. So whereabouts are you at the moment? You're down south, aren't you?
I'm in Melbourne, and I'm really busy, and I'm coming up your way, past where you guys are next week. So I had people that cancel, and I usually try and fit them in, but decided to work a Saturday instead, and it's a bit quieter here to do a podcast as well.
Yeah, the clinic room, a bit like a studio room, isn't it? The clinic room, it'd be nice.
Yeah,
beautiful. So, mate,
in Melbourne, yeah.
Yeah, for the listeners, can you give us a bit of a backstory as to what you do, who you are, and I guess the journey that you've been on and still on?
Yeah, so I think I got into podiatry because I was a runner when I was at uni and an elite level runner, but plagued by injuries. But podiatrists weren't treating me then. I only started getting treated by a podiatrist once I started podiatry school. And, you all make each other orthotics and then stay in them for 20 years, which is what I did. And then got into private practice pretty quickly, although I, at the time when I was at uni, didn't think I'd enjoy working and had a passion for teaching. And so I did an honours year, which was a teaching year as well. And I really enjoyed that. But then I started working and it was just so easy to work. And, it's a lot easier than uni life, I think, to be working in some respects in terms of finances and things. So then I got into private practice in a partnership for, I think, 18 years. But the last 3 years, I started changing the way I was practicing, and a few other things were coming up, and it's probably harder than a marriage to be in a partnership. So I ended up bailing on that, and we had multiple practices. I got one little one where I am now, and that suited me fine. And so the last 3 or 4 years, I've been exploring a different way of treating my clients. It's just still evolving.
Yeah, incredible. So, and I mean, talking about over the years, so obviously when you went to podiatry school, we were very much treating, I guess, the kinematic model of, foot rolls in, plastic underneath, make it neutral, subtalar going neutral, all that kind of thing. So you trained and, I guess, grew up with podiatry when that was, I guess, what we thought about everything?
Yeah, so although I had Craig Payne as my honours year supervisor, and he was the lecturer that I most, you have got an affinity for a lecturer because you like the way and he was really pro making us think and using all these different, and just as long as you could justify why you were thinking away using some model of care, and the tissue stress model was always my go-to. And even when I was in the other private practice, we had our own little lab, and I was probably known as an under-prescriber of an orthotic. I think because I was generally lazy and I had to make it myself. But also it was still always using that tissue stress model. Okay, this is loaded, let's unload it. And so I think I still have that at the core of the way I work.
Yeah.
And I think that will answer one of the questions as well further down the track. But that's was always my sort of modus operandi, and we were explained that then, the tissue stress model, but there was still a whole lot of this way of the foot moving is wrong, and we need to move it to this way. And if anyone you saw, you were trying to get to be this perfect foot, and I now, in my when I'm speaking to someone, when I'm watching them walk, I'm explaining to them, I'm not seeing if they're this far away from the way they should be walking, or I'm just getting a feel for how they move and how that might be loading tissues, and then how does that relate to what's actually going on? I'm not saying it's bad or wrong. I'm just trying to see what they're doing and then how that relates to what they're coming to me for. Yeah.
Andy, you said that you experienced a few running-related injuries before you got into podiatry. Do you think that how that was managed and how you got through those injuries has influenced, some of your treatment philosophies now and when you were becoming a podiatrist?
Yeah, for sure. And they were mostly medial tibial stress issues and stress fractures. And it was like I was an elite junior, running nationals, that type of thing at middle distance. And I had a coach that was really Arthur Lydia, the long, slow distance, build up your base. And to become a senior athlete, you just have to do more Ks. And really, that probably didn't suit me. I kept getting injured. And then I got Steve Ovet's coach. And I don't know if you know those guys, Steve Ovet and Seb Coe. And the Seb Coe was really about technique and gym work and speed. And Steve Ovet was this grinder, and they would meet together in the 800 and 1500 meters and have these massive. So I got Steve Ovet's the wrong coach, the wrong side of the stick, because that was another guy that just ran me into the ground and I just kept getting injured. And so there's nothing wrong with the way my foot moves. But I think when you add all that load to the way I was running probably, and I probably became a plotter rather than a really, my technique probably changed as well. And so putting an orthotic in there wasn't going to help. I never did any mobility work, any strength work. We were worried about, 20 years ago, I was worried about strength work. I didn't want to get bulky as a middle distance runner. But doing 100 Ks a week, it's almost impossible to get bulky. And so if I look back, I'm like, wow, if only I'm sure we all do that. If only I knew then what I know now, then who knows what I could have done in my running career. I quit running for 20 years and I guess, and then I became an elite cyclist. And through a series of falling off my bike and head injuries, I found yoga and my own feet started to change massively. For the first time, I stopped needing to wear my orthotics. I thought I needed to. And my feet were getting more mobile. My whole body was getting mobile. I started going to a gym and training and seeing other people train barefoot. I'm like, there's got to be something to this. And I started running, but getting old symptoms back. So then I was looking to running technique, running shoes, just using my body. And Nick from the Foot Collective probably taught me this, using my body as the first experiment, just seeing, okay, what works for me? And then how do I apply this to other people? Not exactly what I'm doing, but, okay, how am I loading this? How can we change this load? That type of thing. Yeah. So definitely my own experience is continuing to shape what's going on. Even the people around me, my wife has a sore foot now. And so I'm like, okay, so why is this happening? And how would I have treated this before? And when, you're just constantly in your head about this stuff. Yeah. More than ever before, actually.
Yeah.
It's so interesting.
Yeah, well, we'll get cracking with this first question. I guess what I would have liked is, we've got the overarching principles to how you treat. And I think we all inherently have our own principles, whether or not we reflect on them very regularly. But people can see the barefoot content as polarizing, where people say pain is caused by wrong fitting shoes and all that kind of thing, and then associate that with you as a person. And we know there's more nuance to it than that. So for the listeners, what would you say your principles are for your way of practicing? Now, forgive me, when I say barefoot, I just think that people will know that group. I'm sure there's a better name for it, but yeah.
Yeah, and so you might say pro minimalist shoes, or
Yeah.
and I guess there's not many podiatrists this way aligned, and that's why maybe what I'm saying is a bit more like out there, because most people align podiatrists with big shoes and orthotics and things like that. But there are other podiatrists doing what I do, but maybe less vocally. And so I think it comes back to what I said before, this idea of tissue stress model, and it's not, and that probably on social media, it's far more black and white than it is in reality. Like when someone's coming into me, I'm assessing where they're at that moment in time, where they're coming from and where they're going to, and putting something in place that is going to suit them there and then. It's not like everyone is just going into a minimalist shoe. And so I would say my overarching principle of practice is to meet people where they're at, listen to them. They've mostly got the answers for you. And I think I have a very nuanced audience now, in that people that come to me want to be going into a more natural way. They've had experiences with orthotics, or don't want to go down that path, or with other modes of treatment. And they've either heard about me or researched about the way that I work. And so, and they're often highly complex cases now, like they've shopped around, they've done a whole lot of stuff. And so just to actually meet someone where they're at, and acknowledge that, and then move on. It's move on to the next step. It's hardly the barefoot principle to some extent.
Yeah.
Because but then I'm also looking at them as a human, and as how a human should move. And often so much has happened to them, not only their feet, but their whole body, because of westernized society in terms of footwear, office jobs, so much stuff going on, that when we peel this stuff back and go back to being a more natural human, and giving your body the chance to heal, the opportunity to heal, whether that be with more strength or rest or other, good diet, sleep, all these different factors, when we start peeling all that back and having someone understand or seem to understand or acknowledge that they have pain and injury, I think this is my overarching principle. And maybe 2 years ago I would have answered it differently. I would have been like, no, everyone needs to be in a barefoot shoe. I just think it's more about letting their bodies do the job, and finding where they're at that moment. I don't know if that even answers the question.
That's good. That's really good.
Andy, what are the more common pathologies that you do see through that, complex caseload that you just mentioned?
Yeah, well, a perfect example yesterday was a lady with a bunion that had traveled from probably 60 kilometers away to see me, because the chiropractor that she traveled 70 kilometers to see told her to come and see me, because she'd already got orthotics for bunions. She's starting to get claw toes, and she's got met domes in her runners to help her claw toes. So this is all like putting a patch over things. And the orthotic was totally inappropriate, won't even fit in her shoes. And so, and it had been revised 4 times, but still didn't really fit in her shoes, and it wasn't comfortable. And so, so I see a lot of people with bunions in this situation, where they've done all this stuff and they've still got a bunion and they're still having issues with it. And so I said to them, has anyone talked to you about your footwear? And the footwear has not even come up on the radar. Like, it's not even a thing. And so I pulled out the insole of her shoe, of her runner, her most comfortable shoe, and put her foot on it, and her toes are crunched like this in her runner. And so, like, that's a pretty powerful image for her to see. Like, this is the shape your foot's meant to be, and this is the shape it is now when you're in this shoe. And so, like, for her, it's just about getting her head around wearing a different shoe, and some very basic exercises. And maybe in 6 months' time, when she's come to that point, she'll come back to see me. But a lot of the pathology I see is heaps of bunions, a lot of chronic heel pain, because a lot of stuff hasn't worked, and then some really, like, have an hour and a quarter for initial consultation, and some people just need to speak to me for half an hour about the history of their feet, because there's so much stuff going on. And in those cases, I'm just going, okay, what's hurting you today? What's hurting you this week? What's hurting you this month? And let's work on that, and then see how it all falls into the bigger picture, just decreasing goals and things.
Yeah, like talking about bunions, and it's such a controversial topic, is there's genetics, there's shoes, there's this, there's that, and we try to explain it as a whole spectrum of treatment. There's lots of things that you can try. Like, what's your take on them, and kind of their etiology, and also how do you explain them to patients as well, like the analogies and things that you use?
So I definitely would say that I start out by saying there are genetic factors that have predisposed you to having this happening to your foot, and then there are environmental factors as well, and it's when those two coincide that we end up with a bunion, and that's in a perfect world. Like some people don't have the environmental factors and might still get a bunion. Some people don't have the genetic factors and still get a bunion. But I think the genetic factors are, and this is how I explain it, are triggered by the environmental factors. And it can't, if you go to any local kindergarten, there are 99% of children, possibly 100% of children, in shoes that aren't widest at the tips. And the message when those kids were first walking was to have a shoe that's widest at the tips, to have a shoe that's thin, flat, and flexible. But when they go to kindergarten, when they're 2, 3, or probably 3, 4, 5, they're in their little shoes that are squishing their toes. And so if they have a predisposition to having a bunion, that's a very early start on a very flexible foot to start changing that. And then, I mean, it's a given amongst all the podiatry community that a really pointy shoe and a high heel increases the chance of a bunion. That's a given. So it's not that, I don't think it's that big a step to say, let's go back a step and say that any shoe that is squashing your big toe sideways may be a precursor to a bunion as well. It may just not be as big a precursor to a bunion. But if you're going to say that a really pointy shoe is going to help trigger a bunion, then any shoe that is pushing that big toe sideways is going to have an effect on the mechanics around there. Yeah. But obviously there's stuff going on up the chain. There's so many different factors, and I'm assessing someone for all of that and working out what individually is the issue. I like but, just quickly say, if we don't change the shoe, we are just like moving deck chairs on the Titanic. Because if you don't change the shoe, you can put the toe spaces in, you can do all the foot strength, you can do all the mobility, you can do all the core strength, hip strength, all this type of stuff. If you keep putting your foot in that environment 8 hours a day, it's like, you're on a hiding to nothing. It's very hard work.
Yeah. I like that you've said, it's not, and I think that the social media stuff can be polarizing to people because they see it and I think they take it as the community and your community saying shoes cause bunion, full stop. And then obviously, like you said, social media is black and white, but you're not saying that at all. You're saying it's an increase, maybe a risk factor. We don't know how much. It could be a lot, could be less, but it's more meaning the person individually and seeing where they're at. The shoe may play a big role or it may not play a huge role, but it probably is in there somewhere.
Yeah.
How and I feel like I'm going controversial topic after controversial topic.
That's what I'm here
for. How do you use orthotics in your clinical practice, and what general advice do you give with them?
So I mean, I've got a lot of history using orthotics because I used to make them myself, which gives you a real insight into how they work, I think. But I never had a great feeling about them. Like I was always like, I don't want this to be something I just rely upon, But then I had clients in them for 15 or 20 years, and the hardest part of me changing the way I practice is when that client comes back for a recover or because they think they need new ones or whatever, and me explaining that I have changed the way I practice and they may not need them in the long term. But mostly it's a very positive outlook because people inherently trust their provider. Do you know what I mean? And so I'm not abusing that trust. I'm just saying there's another way. And some people are like, you know what? I love my orthotics. I'm going to stick with them, and that's fine. But I tend to not see those people so much anymore. Like I'm not even set up to do much orthotic work. I've got a podiatry practice just up the road here that like maybe 5 kilometers up the road, and the husband and wife were at uni the year below me, and I use their lab. I just go and use their lab whenever I need to do orthotic work. They just very kindly let me, and I might send them. Like I have some people ring up and say they need orthotics, and I explain on the phone that I may not put them down that pathway. I'll just, if they're like, no, I need them, I'll just send them to that practice down there. It's not. I don't want to be just giving someone an orthotic unless they really need it. And so because when someone says I really need an orthotic, they don't know that, and so that's my assessment might say you don't really need it, and so but who am I to say that to them? If they really want it, then and a practitioner is willing to give it to them, I'm just not that practitioner. My standards are that I won't do it unless I really think that it must be done, and so. Then if I do use orthotics, I might use form orthotics first and foremost. They're so highly adjustable that I can make as good a customized device out of a form orthotic as any scan. Like, answer me this, and one of your posts a long time ago triggered my way of thinking this. We take a scan of a foot that's non-weight bearing, with measurements that don't even have any clinical relevance, really. And make a prescription on something using a theory that's hard for us to understand, let alone explain it to someone who's going to wear the thing, and is outdated and has poor research-based relevance as well. Yet we do this systemically. We do this like this is a custom-made device, and we even now just take a scan. It's like a totally non-weight bearing scan. And like, I used to just use plaster casts, and then I'd be putting plaster on that plaster cast, and always thought, I'm just moving this foot away from being this orthotic, away from being customized. So I reckon off-the-shelf devices, if you know how to adjust them, like I've had 2 cases recently. I have a physio that I work really close with. She sent me the first one. He'd had a peroneus longus, snapped it and hadn't had it repaired, wasn't going to get it repaired. So really struggling to get the big toe joint down to the ground. And for those listening that don't understand that, the muscle on the outside of the leg wrapping around the base of the outside of the foot is really important at grounding the big toe when we're pushing off. And so this guy is a runner, he's a physio himself, and he's just toeing off laterally and really like struggling. So I used a form orthotic, which I ground down to just as a means to get a 4-foot lateral wedge in, to get some weight over to his first. And it's making a huge difference. I've done that twice in the last couple of months. For another guy that had the surgery after snapping peroneus longus, where he's now got it attached to peroneus brevis. So he's still not getting that first ray stabilization from peroneus longus. So we've pushed him down into onto his first with a lateral 4-foot wedge. So that's the type of thing I do now. Or like that chronic heel pain that I've tried everything for they've and been really good with their programs that I set out for them, and changing shoes, doing all these different things. And we might put a very simple insole in, just almost proprioceptively. Or I had a tib post rupture recently. Like, I saw her 3 months down. Another podiatrist had not explained things that well to her, and she'd had a scan for an orthotic but didn't think she'd signed up for it. And then when I saw this foot, I'm like, this looks like accessory navicular. This looks like a tib post rupture. You've got to get a scan, because I can rehab this to the cows come home with you. But if those things are going on, it's going to make it really hard. Scan, accessory navicular, and 9mm snap in the tib post. And so, and then when I'm talking to her about this scan on the phone, she's like, the other podiatrist rang up and my orthotic's ready. I didn't even know I was getting one. I'm like, well, now is the time to use that orthotic. Like, I want you not that orthotic until you see the surgeon. And that's a great stopgap to get you through to that point and then we'll reassess. So this is exactly how I use it.
On that, those patients, would you say like that they will probably benefit longer term? And it's such a narrow indication, but would you say that they would probably, and again, not to say they have to, or when we say longer term, it might be for a couple of years. Like, do you think that those are the kind of people that probably do benefit from it longer term in combination with strength and rehab and proper fusion?
So like as in that peroneus longus and tib post, so those types of things, I would say they don't generally ask. They know where I'm coming from and would see it as a short-term thing. But I would say that maybe you'll always use it when you go for your walk every day. But these people tend to love being barefoot or love trying to do less. They're having less coming at them, So they've generally got a goal of not being in it all the time. But I would definitely educate them that this might be something you have for certain activities, like it's just all about managing that load. Like, I would hate to tell people they can't walk barefoot on the beach, because most of my clients want to do that.
All right. Can you just say something that I don't agree with?
Oh, no, sorry.
I'm trying to make something a bit polarizing.
Can I just say
something wrong?
We chat a lot, or I write a lot, and you send me
the voice messages. You're not the only person that says that. I apologize.
That's all right. So, and what I think when I started out doing this way, podiatrists, I just saw it as very black and white. But there's a few of you now that I say, hey, we're doing this stuff, but we're just doing it with the nuance of what you learned 20 years ago as well. And so it's really comforting, or I'm excited about the future of podiatry, because there's people with an open mind, whereas I think the old school podiatrists don't even know that we're having this discussion. Like, it's not even in their heads that it could be a possibility not to do what they've been doing for the last 20 years. And you can CPD till the cows come home. You're not going to hear this stuff yet, but I think the more we talk about it, the more it's going to get out, and then they'll either be forced to change or they'll slowly leave the profession. And, you know, in 20 years' time, we might see some different styles of professions. Yeah, the profession. Yeah.
Another question, Andy, on the like orthotic sort of conversation again. So, for example, someone comes in with like a peroneal tendinopathy or something like that, and you decide, you know, maybe not to give them an orthotic. Do you find that rehab timeframes are a little bit longer when you're not offloading it or following, you know, maybe a tissue stress theory, or how are you sort of approaching that?
I reckon podiatrists are often not, in my experience, the first port of call for foot stuff. They're more likely to go see a physio for an ankle sprain, or their GP. And so when they finally get to me 1 or 2 months or 3 months or even more down the track, they're at the chronic stage, you know. And so offloading is not really, I don't think it's really that helpful at that stage. We want to get it more stable, more loaded. And peroneal tendinopathies are really interesting. They do really what I'm finding, and this is still kind of fresh for me. It's not like I've got peroneal tendinopathy every week, but I might see like 2 a month or something like that. And so, but what I'm finding is that more stable that foot is. Like, we see the peroneals working overtime to stabilize a foot. If you think about what a Bosu ball does to foot stability, it's like your foot is working so overtime. You see the ankle working overtime. And so when we look at a shoe that's full of cushioning, you see the foot working overtime. And so I'll even give I'll give them the choice of going into a cushioned flat shoe that's allowing their big toe to be able to be used, so you can plant it and use it, or go into a fully minimalist shoe. Like, this is one of the cases where going straight to a fully minimalist shoe in a lot of cases is working amazingly well, because they have the ground is firm and their foot is just searching for stability. And so when you have any cushioning under it, the foot is having to work harder. So you're deloading the peroneals from doing this like micro movement of stress, and just giving it an opportunity to actually pull on the big toe and work the way it's meant to. So this is just a nuance. There's nothing written up. There's no evidence about this. I'm just finding that it works really well when we just get someone being stable. Heaps of balance work on stable surfaces. Like, when are we walking around on a Bosu ball? When are we doing stuff on a Bosu ball? We're not, unless we're on a really big cushion shoe.
Do you find, like, if the option was there, and I'm guilty of it myself, we were talking about sticking with the peroneal example, into, you know, a shoe that's laterally more stable, and I think of, you know, a Brooks GTS with maybe a lateral wedge or something like that, in comparison to a flatter, more cushioned minimalist shoe. Do you see that they get better results with the minimalist shoe because logically it makes sense, a laterally stable shoe should unload that peroneal tendon a little bit more, but you're saying that the flatter, more ground contact usually works a little bit better?
Yeah, it does. There's no cushioning. When there's no cushioning, they seem to be able to stabilize better.
Yeah.
But to answer your question more, Kelly, like at the timeline, is it slower rehab? Like I said, often they're a bit later in stage anyway. So, but even in those early ones, like if they are acutely sore, we need to get that under control. And so we're in there with pain, what I call like a little pain management routine of like heat, gentle movement, stuff that's telling their brain this is okay, you know, like ankle rotations, ankle mobility work, foot mobility, some very basic things, and a big plan of isometrics as well, like heaps of that. Like, they seem to work really well with my clients for most things, like in terms of pain management. So we're hitting them with all that stuff first to settle it down, and then at the same time changing that environment that's caused the issue often, whether that be load or footwear or work, you know, a whole lot of things.
Yeah, we talked a lot about, and I know you and I talk a lot about this online, and I love it because, I mean, up until 3 months ago, I didn't even really know what the Topo brand was, and now I probably send for 3 or 4 every day, if not one every single day. And I wanted to tell a story about a patient that I had recently who'd had a bit of a flare-up of a 5th MPJ, had been referred to us for an orthotic to wedge laterally, and yeah, looked at that, and it wasn't really painful mechanically to test it or to hop or jump or bend the big toe. It seemed more just compressive pain, and thought, it might be it seems like it's probably your shoe. You've got a pretty wide, flexible foot. Why don't you go and grab a Tobo from one of the local shoe shops? Went and got that. Saw him a week later, and I'm thinking maybe still use your thought. If we talked about we might use it, come back in, and pain was completely gone. And definitely not saying that happens all the time. However, I would have completely missed that, a complete blind spot of mine, if I had not been probably following your stuff and learning a little bit more about this world. And I imagine all the things and patients that I've missed over the last couple of years, where that's probably been the case.
Yeah. Well, don't beat yourself up about that. Like, that's the way it is, isn't it? You're always like, I could have done better, or if I'd known this or this, hadn't known. But like the idea of this, and there's a question relating to this that you're probably coming to, of this wide toe box, and that's the way the foot is anatomically designed, to the point that we wear that conventional shoes are not that shape at all. So it's become normal to see a foot is not widest at the tips of the toes. And that's a baby's foot shape. And then because every human that wears shoes pretty much is in a shoe that compresses the toes, the normal foot shape is now a compressed toe shape. And so for me, like in a minimalist shoe, we're looking at it being thin soled, so that so you can feel the ground. And I see that as negotiable. Flats from heel to toe, that's negotiable depending on what we're trying to achieve with a client. Flexible, so the foot can move. Again, negotiable depending on what we're trying to achieve with the client. The first one, which I skipped, is wide, and that's the non-negotiable for me. Like your toes, have to be able to move. And I know a lot of people are like, what's so big about the toes moving? The muscles of the foot are attached to the toes. If you're not going to be able to move them, how are the muscles of the foot going to function properly? And people like wriggle their toes in there, squish. This is not toe movement. Natural toe movement is the ability to splay. And there's a physio in Finland who's obviously aligned, part of our community, as you call it. She's got this little video of her, and I've posted this, of her like 2-year-old walking and looking down at the foot. And as the heel hits, before the heel hits the ground, the foot is just at rest, basically. And then the heel hits the ground and the foot just does this splay, just spreads out and accepts the ground and presses down onto the ground. And as it pushes off, it springs up again. This is what's meant to happen as our foot moves every time. And if our toes are like this all the time, that's going to have an effect. Whether that be how that relates to pathology, I have no idea, but I know
things like that.
So much stuff. Yeah, so much stuff. And so that's my non-negotiable in terms of footwear. It's got to be wide, which relates again. And so that relates again to another question that you'll probably come to is like, where do I go with the plantar heel pain? And are they all going to minimalist shoe? Like, that would just be suicidal in terms of my career to be putting people with heel pain. It wouldn't make me feel that good either. Like, definitely, if I'm making people hurt more.
Yeah.
Although maybe it would be like shockwave therapy. The pain would be so bad you'd forget about some other pain or something.
Kelly's good. We'll shockwave her shins a couple of times, and we can only do it once because she hates it.
That's right. Well, same. My son got some warts on his knees when he was about 4, and I used liquid nitrogen on them. I would never freeze another child because anyone ever again. Because like when I'm seeing my own son in that much pain, I'm like, I can't do this to anyone else anymore. So like I would then definitely use some cushioning in a shoe, maybe even a little bit of a heel lift to take some load off. Yeah. But definitely we want to be able to splay those toes so that we can get some good blood flow, good movement in the area,
Yeah. And I think, and again, we talk about a lot online now, I think about it, because I feel like I'm starting every question with that. I tend to think, and I'm just going to talk from my own experience, that, with footwear, I think a lot of people, just from a lack of knowledge of specific shoes and what to recommend, probably don't know a lot about which shoes to recommend in the minimalist category. And I was just mentioning before, like Topo and Ultra, but if you were to ask me a work boot, I only know one, Wide Load, found them a couple of months ago. And in the ladies' shoe, I couldn't actually tell you any category at all. So what do you think, general categories, where can people go, websites, and then how do you kind of educate them about the shoe itself?
So there are 140 barefoot shoe brands at the moment. So this is a massive industry. Yeah. And I don't know how many normal shoe brands there are, but 140 barefoot shoe brands, and they're popping up all over the place. So because there's such a demand for it. So there's in social media, there are great resources. The best is Anya's Reviews. This is a woman in America who has listed every, like she's as far as feet go, a layperson, but through her own experience, and then is obviously entrepreneurial enough to set up a business, but has become quite knowledgeable. I would suggest more knowledgeable than a lot of podiatrists when it comes to natural foot function. And so, you can go to her website, Anya's Reviews, and see your foot shape. Like she's listed the 6 or 7 different foot shapes, whether it be like a long first toe, all the different foot shapes, and then go from there. And it goes through each, whether you've got a more mobile foot, how to test for it, a more stiffer foot, and these are the shoes that will suit you. And this is like the shoe for you, because it's not one size fits all. It's not like, okay, everyone should be in Vivo barefoot. They're so popular because they've got a huge branding and huge spread across the world, but they tend to be the most narrow and shallow of all the barefoot shoes. And so they suit some feet, but not all feet. And I could say with my clients, I would say 90% of my clients that come to me for me to talk to them about a musculoskeletal issue, they have wide feet. They have wide compared to normal feet. So I'm seeing a part of the population that is more affected by conventional shoes. If I was seeing 90% of people with really narrow feet, they're going to be far less affected by conventional shoes, obviously, because a narrow foot fits in a conventional shoe more easily. But yeah, I'm definitely preaching to that group of people that are struggling to ever fit their shoes on.
And are you pulling out the sock liner and just showing them? Because sometimes it can definitely be hard. We joke in the clinic, where fashion meets function, you got to meet in the middle because everyone doesn't want to wear what you recommend. Do you just pull out the sock liner and hold it to their foot and say, you can see the issue quite clearly. Yeah. It's probably why I think you need to go in this shoe.
I did that yesterday with that lady I was talking to you about. I don't often do that. I'll show them how the big toe is meant to work as a hinge, and then I'll say, look, your toe's in this angle, and if you're in this shoe, and this is where the hinge is meant to be, look at the angle that hinge is on when you're functioning, so I show them that a lot. Like I said, I see a lot of people that already know this stuff or are understanding, and they want to get into this stuff, and so they've got a foot problem and want to go this way rather than traditional way. But for podiatrists out there listening that aren't seeing that population, it's and thinking that a wide shoe is going to be better, just think about how that big toe is meant to act and how important it is. And then is that actually happening in the shoes the person is wearing? It triggers, using that big toe triggers a positive effect all the way up into the pelvic floor when we push off. And so if we're not using that big toe properly, we are missing out on a whole chain reaction of events in the normal human gait that are I almost think it should be a movement all about the big toe, really, rather than, it's about having that big toe working. We gave up the ability to use our big toe as an opposing digit to be able to stand up straight. And then we put shoes on it that pretty much render it not working. How many people are actually wearing out where their on their shoe where their big toe is? You look at nearly every runner's shoe, they're wearing out second, third, fourth met heads. They're just low gear toeing off with every step. Yeah. With its multitude of effects. But the human body's amazingly adaptable. So, because the argument is, well, not everyone's got foot pain, and most people are wearing these conventional shoes. We adapt. Our bodies are amazingly adaptable. Doesn't mean they're functioning as well as they could.
And so, moving on from shoes a little bit, how else are you managing your patients? Is it involving some sort of intrinsic strengthening or some sort of strengthening, or what else would you do?
So I'm assessing them first to see where the red flags are that I might call it, and my language about this is very important. Possibly almost one of the most important parts of how I consult is speaking to someone very positively about their feet, because a lot of people have very negative connotations and ideas about their feet that have been set up from a very young age, whether it was grandma saying you had flat feet, or the podiatrist saying that you need orthotics for the rest of your life, or you've got this foot type which is has negative connotations. So straight away, I'm assessing someone and explaining what I'm seeing while I'm assessing, explaining how I assess, so that they're part of the process and they're feeling what I'm saying. They're able to experience what I'm saying. And that might be like, look, you're one of the best shock absorbers I've ever seen, like your foot is shock absorbing beautifully. In the past, we'd be like, wow, look at that foot. It's rolling in so much. We got to stop that,
Yeah, how are you still alive? Look at that foot.
That's right. And then, but hey, look, when you get to that point where your big toe hits the ground, we want to see you pushing off more efficiently. And that might be something we can work on that. We can be stronger in that. And this is how we're going to do that. Let's look how mobile your ankles are. Like, why are you so efficient at shock absorbing, and why are you less efficient at pushing off, for example? I'm just using this is the lay terms that I use. Okay, is it a mobility issue? Let's work on some mobility. Is it a strength issue? Let's work on that. And then I tend to try not to